Cancer Hospital in New Delhi. So when we talk of the head and neck cancer, the situation here is that the head and neck cancers in India is increasing enormously as compared to the other countries, other Western population. The reasons could be many: the low socioeconomic conditions, the habit of tobacco chewing, the poor oral hygiene. But the incidence of head and neck cancers are increasing, and hence the workload of providing them a surgical care, and also sometimes the other procedures like radiation therapy do require the airway management in these patients. These airway tumors can be of various places in the head and neck type. It could be the buccal mucosa, it could be the alveolus, it could be the tongue, it could be the mandible, maxilla, and the neck areas, including the thyroid glands. And these tumors usually present sometimes late to us, which creates further problem during the airway management, just not the surgical procedure. And hence, broadly, just I need to divide them into categories as supraglottic, subglottic, thyroid tumors, secondaries in the neck, which sometimes they are posted for, and the glands tumors. So these are the tumors that we are taking care of, and there are specific concerns in them. Why these patients do come to us? Why do these patients require the airway management? Sometimes these patients come to us as anesthesiologists for diagnostic procedures, maybe the endoscopic examination for biopsy or looking for the other metastatic workup. At times they come for the definitive procedures, definitive oncological surgical procedures and the reconstruction. And at times they also end up with advanced surgeries where we have to provide them a surgical airway. So these are the situations wherein the primary airway management needs to be done by us as anesthesiologists. Let's see this patient first. I just put my ground on this patient, a 42-year-old male patient with carcinoma left cheek, posted for hemimandibulectomy with the reconstructive procedure. He's a chronic smoker, taking one pack for the last 25 years, and he's also alcoholic. These will be a situation in majority of the patients who come with head and neck cancer, maybe the thyroid cancers also. Now, what and how we'll go ahead for airway management these patients. So when we talk about the airway management, the concerns will be at all aspects. One is the assessment. They require a different procedure for assessment. We have to plan and prepare ourselves for various techniques. We have to share the airway during the procedure, and hence becomes difficult. Extubation again is very challenging for this, and post-operative complications can happen in these patients like bleeding, edema, and hence not only at the extubation, but after extubation in next 24 to 48 hours, these patients can land up with complications like bleeding, and hence require re-airway management. Hence, the whole process of airway management in these patients are always challenging. And these challenges are primarily to regions related to the patient itself, related to the surgery that these patients are undergoing, and comorbidities. As I mentioned earlier, these patients are usually tobacco chewers, alcoholic, and so on and so forth. So probably they would have other issues also. When we see the patient-related concerns for these patients with regards to airway management, obviously the airway is difficult because the tumor mass may be on the path of airway or it can distort the airway. Similarly, if you want to do an emergency tracheostomy, there could be a neck mass and hence tracheostomy may not be possible. These patients probably would have received preoperative radiotherapy and chemotherapy, or maybe the prior surgery, and hence these patients would lead to these procedures, these interventions will lead to more issues with the airway management. Surgery, we are sharing the airway. The surgery is being going at the same place, and hence the airway is being shared. This will be the intraoperative problem, but also the surgical management or surgical intervention will distort the airway further on, and hence the extubation and post-operative issues may be a big concern when we are managing that. The associated comorbidities, especially the tobacco chewers and smoking, these patients can have associated issues. And when we are managing the airway, for example, an awake intubation in a hypertensive patients, when you're managing the BP will surge, even a small bleeder during the airway management will bleed a lot. And hence we should be very, very careful during the airway management. And that's why I'm putting this forward. These patients at times are posted up for surgery, and before surgery, they have undergone radiotherapy and chemotherapy, especially like squamous cell carcinomas. And these therapies do have local and systemic effect. When the radiation therapy is exposed to the head and neck area, it leads to edema, the fibrosis, the whole airway is fixed. We cannot move the tongue, we cannot distort the structures. When we talk of the optimal external laryngeal manoperation for airway management, This sometimes is not feasible in these patients and hence becomes an issue. Also, these patients can have a lot of mucositis and trismus, hence the mouth opening may be reduced and may be painful also. And we should be cautious when we want to manage the pain. If we give morphine, we are concerned whether the airway depression, airway obstruction can happen because of the respiratory depression. Mask holding and whatever the airway management techniques would be issue when we are managing these patients. Also, there could be effect on the lymphatics. It has been very well seen that there are a lot of periglottic edema because when they receive the radiotherapy, there will be lymphatic obstruction. And hence we try to intubate them, try to look for the area whether awake or with the laryngoscope guided. There will be a lot of periglottic edema because of this lymphatic obstruction. And this edema is very fixed. So you'll not be able to manipulate when you're managing these airways. And hence, just to summarize that after the radiation therapy or the chemotherapy, we should anticipate difficult airway because the effect of radiation, the effect of chemotherapy on the airway is enormous and it can lead to issues during the airway management and the extubation also. To summarize, when we are looking for the patients with cancer, the radiotherapy and chemotherapy have local and systemic effect, which requires assessment preoperatively. Also, the airway management becomes more difficult after head and neck radiation exposure. So this is the key point that we should remember in these patients. And hence our pre-anesthetic evaluation, apart from the comorbidities I mentioned, you should be looking for a holistic airway assessment in these patients. We do a lot of help from the imaging here. Most of these head and neck cancer patients would have undergone a CT scan prior to surgical procedure for the resectability. So we should be in a habit to look for the CT scan. At times in a difficult airway situation, we also go ahead and do a 3D airway reconstruction to look for actually the difficulty in airway. That is very, very helpful. So as anesthesiologists, you should be well versed along with the radiodiagnostic people to assess these CT scans. And hence, history examination, the clinical examination of the airway, and the assessment of imaging will give you a holistic assessment of the airway management. Also try to look for the other concerns which we discussed earlier, the impact of the radiation therapy and the chemotherapy in these patients, and hence also needs to be looked for when you are assessing these patients, whether the patient is having mucositis, whether they are loose teeth because the patient is tobacco chewer, there could be some mucosal fibrosis. And hence to summarize once more, when you are assessing these patients would have difficult airway with regards to difficult bag and mask ventilation, difficult laryngoscopy, difficult supraglottic airway placement, difficult invasive airway, difficult fiber optic, and hence you need to prepare yourself, plan yourself for proper airway management. Also in head and neck cancer patients, this cannot wait for long. We cannot transfer the patient to different places, and hence no unnecessary investigations or referrals needs to be desirable in head and neck cancer patient because cancer surgery is a time-sensitive surgery and one cannot delay it for a long. So to summarize, just to have a key point here, when you're managing these patients, keep difficult airway cart and surgical airway tool along with an expert who can do this procedure even at the time of extubation. That's a key point when you're managing these patients, that this should remain in your operating room throughout the airway management. Also, in case of any doubt, we have a lot of availability of options. We were discussing about the supraglottic airway devices. We were talking about video laryngoscope. We have many things in our armamentarium for the airway management. But remember, in any doubt, if you have any doubt, don't take away the things which you cannot replace. So don't take away the patient conscious levels. Don't take away the patient's respiratory efforts. Have awake fiber optic airway management in case if you have any doubt for the airway integrity. You need to follow an algorithmic approach. You need to have plans for failures. Try to have a primary plan, a rescue plan, a failure plan, and these can be based on various algorithms. We have many algorithms which are available now. You can use any one of them and try to manage your patients. We do have our guidelines from our own country also, which is very well suited for management of difficult airway, which follows a stepwise approach. So when you want to think of the head and neck cancer patients also, try to think of which will be the best process. Any doubt, go ahead and do an awake airway management in these patients because this will save time. This will save any occurrence of complication and the patient outcome will become much better. If you talk of the awake tracheal intubation, we have a good guidelines from Difficult Airway Society, which talks of the basic principles of awake airway management. They talk of basic 4 principles that they talk of oxygenation. Now, this is an important aspect in which I want to spend just a minute or so. We are having devices now which can provide the supplementation of oxygen in high flows. And in COVID times, we have already seen them, the benefits. So in difficult airway situation, I think we should all start taking away those HFNOs which we're using in COVID and keep in OT. I think this is the right time after the 3rd wave, because in difficult airway, the use of HFNO is absolutely very useful. Try to use it because it will increase the apnea time, and the use of HFNOs and thrive will give you more time for airway management. So oxygenate your patients appropriately. Give a local anesthetic agents to topicalize the airway so that you can do them comfortably. There are various options, including the use of the sprays, use of the gargles, use of the nerve blocks. Use them appropriately so that you get uncomfortable patient. And then perform your patient's airway management. Explain the patient properly, clear the secretions, and then go ahead and do awake trachea intubation. The use of sedation is a concern here. Be very cautious. A cooperative patient is required, and hence a judicious use of sedation is a good option in these patients. Do look for various procedural complications in these patients. There could be at times the obstruction, which is quite obvious. You need to remove them. You need to remove the secretions. Don't try to have multiple attempts. In case you have failed in first, second attempt, think, what next? What can you do better than this? Call for expertise, call for help, and then review everything and try to provide them uncomplicated awake trachea intubation. Now, this is a good algorithm where the Difficult Airway Society has put up the management guidelines for unsuccessful awake trachea intubation. Now, I mentioned that the preparation and the first plan should be very robust, very well planned, very well thought of. Do supplement them with 100% oxygen. Use now machines, now equipments which can deliver at high flows also, like HFNOs, or you can use the Thrive machines, so that Thrive equipment, so that you can deliver high percent of high FiO2 of oxygen for these patients, so that you can have more of apnea time. But in case if you fail, if your attempt for awake trachea intubation fails, you stop. You think, what's the next step? What's the plan B for you? Can you postpone this patient? Yes, it's a awake patient. You can postpone for some time if it's not absolutely a life-threatening emergency. But if it's not possible, if it's a life-threatening emergency is happening, as can happen in post-operative period, then think of what next can be done. Think of whether surgical access would be possible. And hence, each anesthesiologist should be very well versed with securing a surgical airway. Emergency surgical airway and emergency surgical cricothyrotomy is the procedure which each anesthesiologist must be well versed, because in head and neck surgical procedure, this will be required not very often, but if it requires, it can save life. And hence, the surgical access, the emergency cricothyrotomy, the equipment required for it, and also how to do it, must be well versed with this. Having said that, coming to the extubation part, equally difficult would be the extubation. If you see such type of procedures in which the mandible is removed, you can see the structures here. The reconstruction is happening, either the artery-based flaps or maybe a free flap sometimes are done. And once this reconstruction is done, the extubation becomes more difficult. There will be a lot of edema in these patients. There will be a lot of risk of bleeding, some amount of oozing, and hence majority of times these patients are postponed for extubation approximately a day or so that the edema are settled down. And if there is any bleeding, that can be observed for some time, and hence we need to wait for some time for these patients to extubate, and they are not done immediately after the completion of the surgical procedure. Also, we need to remember that before extubation, these patients should be appropriately, for 24 hours, they should be ventilated with appropriate sedation. These patients would be having a lot of pain, and hence that also needs to be looked for. Now, these things are important because if the patient is not comfortable, if the patient is painful, they may not have good breathing efforts, they could have obstruction, and hence we require more cooperation for the patient. So post-surgical procedure, post-surgical intervention, before extubation, give a good comfort to the patient, look for whether there is airway edema or not, look for whether there is any bleeding site or not, and then try to extubate it. And we have good guidelines from our country itself, which provides an algorithmic approach, the limb approach for extubation. Now, here, if you see the limb approach, if you see the third limb here, that provides very, very clearly at how a plan can be made for extubating. Look for the leak here, plan yourself, prepare, perform. and then post-extubation care. And when we talk about the extubation techniques in these patients are many. We do not know whether the after extubation patient can have obstruction, whether there will be some issues with the airway, and hence the use of airway exchange catheters remains a good option. The use of monitoring tools is very, very essential for these patients, because sometimes these patients can have complications, and do observe your patients. The monitoring of capnography is one of the good options you can do for these patients. Now, coming to the other aspect is that why don't we do tracheostomy for these patients if we are facing for difficult airway? Many of times, if you say somebody is having a CA tongue or a CA mandible, why don't do tracheostomy? Why to land up in a situation where we are struggling with difficult intubation, difficult extubation? Do a tracheostomy straightforward. But in an oncology setting, tracheostomy is not a good option, because this can reach the plane of oncology, reach the plane of surgical plane for the oncology management, and there could be a chance of the metastasis to happen when they are doing prophylactic tracheostomy. And hence, the tracheostomy is not a good option, and we hardly do any tracheostomy for these patients, and majority of patients remains on endotracheal tube and they are extubated post-surgically. Only a selective group of patients will do a tracheostomy where the support system of the airway, especially when the central arch of the mandible is being operated, where the tongue is not supported. In those situations, we do a transcatheter tracheostomy, that too after the surgical procedure. And hence, tracheostomy is not a routine procedure, should not be attempted for head and neck surgery. It affects the oncological outcome. And thus, the decision should depend upon tumor stage, the location, the extent of resection, the bony reconstruction, and whether an extensive bilateral neck resection which is being done is required for these patients. And these patients, usually we usually decannulate them within next week or so that the surgical outcome becomes better, because these patients would require radiation therapy. Just last couple of slides. In head and neck cancers, we have certain specific procedures which are called brachytherapy, like CA tongue or CA buccal mucosa. Head and neck cancer, these patients would be receiving radiation therapy using a specialized techniques which delivers the radiation to a cancer area, and this is done by brachycatheter. If you see in these pictures, these are the catheters which are inserted around the cancer area, and the radiation is delivered focally onto the cancer area using these catheters, and these catheters are called brachycatheters. And these insertion requires multiple insertion, usually around 8 to 10 catheters are inserted. These are very painful, can lead to bleeding, and hence the management of airway is again a big concern here. You can see that this patient is getting the surgery done, and we have put up a nasotracheal intubation for this, because they require an uninterrupted oral cavity for the insertion of these catheters. At the end of the procedure, these catheters remains in situ. We usually extubate them, and they continue to receive the radiation therapy with these catheters. But thus, we need to remember that sometimes these catheters can bleed, and hence a good hemostasis must be ensured while these patients are being extubated. Also, we should be careful while we are taking care of the extubation part for the purpose of flaps. When we extubate these patients, the flaps are having a very compromised blood supply. So we should be very, very cautious when you are extubating that not much of maneuverability is being done. The head extension may not be allowed in these patients, and hence we should be cautious that the flap integrity is not hampered during the airway management, especially at the time of extubation. So to summarize here, that when we're talking about these specialized procedures, you should be careful at the time of extubation, so that during the airway management of the extubation process, you're not compromising the integrity or the perfusion of the flaps. Now, the other aspect of the head and neck cancers are the neck masses, especially the thyroid glands, big thyroid glands, and these issues can create a lot of airway concerns. If we see the swellings in the neck, majority of time we are usually concerned with thyroid gland. I may not be going into the other neck swellings, because thyroid gland is a major concern where it can have an impact on the airway management. In India, so many of the patients sometimes very late. They could be goitrous mass, they could be cancerous mass also, and that can lead to not only a difficult intubation, but a risk of bleeding and difficult extubation. The concerns are many. Depending upon the site of neck mass, these patients can have the obstruction at the level of supraglottic, glottic, or infraglottic area of trachea. Large thyroid mass going into the rectus channel, it will have infraglottic obstructive issues, and that needs to be taken care of. So in such cases, there could be a difficult bag mass ventilation, difficult intubation. Supraglottic airway is not a big issue, is a big concern, because the obstruction cannot be negotiated by these type of supraglottic airway devices. Surgical access is not an option because of the large neck masses, and hence the use of regional blocks is absolutely not an option. And the extubation again is a big issue because persistent, long-standing neck mass can lead to tracheomalacia and hence needs to be taken care of. The option remains, the gold standard is awake fiber optic intubation, but with the use of or the emergence of video laryngoscope, these are being used more commonly nowadays. And the supraglottic airway devices are only used as a conduit for putting up a tube through it. They are not the primary airway management strategies for these patients of the neck cancers. Tracheomalacia is an important aspect after the surgical procedure because the support of the gland is gone away. The trachea can collapse, and hence during extubation, you should go ahead and do a leak test before you extubate these patients, keeping the difficult airway cart ready whenever you are planning extubation for these patients. The difficult airway cart, as mentioned, should be with the patient throughout the procedure and also in the post-procedure process. So this was the machine I was talking about. I think this has changed a lot in the airway management and difficult airway situation. We should be ready. I think all the anesthesiologists must have seen this equipment during the COVID management also. I think it's the right time to grab this equipment and put in the operating room, and we can help managing the difficult airway using this equipment that is very, very useful. The ultrasound is an emerging tool. It has been found to be a very useful tool for difficult airway management. It has been seen in many situations as a part of not only for airway assessment, but also for dynamic airway management. It can look for many things in the airway. And it has a very promising role in the coming time wherein we can see that the ultrasound will become a bedside tool for airway management, a dynamic airway management, and its role in head and neck cancer is also emerging. And I hope in the near future, we could see its more utility. So to summarize my talk for the day, when we talk of the airway management in head and neck cancer, a holistic assessment is required. The impact of preoperative chemotherapy and radiotherapy, and also the impact of cancer on the airway should be holistically assessed using clinical parameters, the physical assessment of the patient, and also we should look for the imaging. Awake fiber optic tracheal intubation remains the gold standard for difficult airway in head and neck cancer patients. But with the emergence of video laryngoscope, the emerging role of video laryngoscope is also an important aspect, especially the hybrid technique of airway management is important. Careful and controlled extubation in a planned manner is very much essential for patients after the head and neck cancers, and we should monitor them very, very in a controlled environment in the post-operative period also. Head-up position in the perioperative period is very important to decrease the edema, and hence it is very essential to monitor them in the post-operative period at least for 24 to 48 hours so that we can prevent any airway catastrophe. So thank you so much, and I'm open to any questions and comments from the eminent participants who are listening to us. Thank you so much.
Sudarshan sir is not feeling well. I think he has taken a permission to leave. I call upon Kumar sir to take over and.
Let Edward sir can proceed with the discussion. Sir, please unmute, sir. Edward sir, please unmute.
So there is one question, Rakesh. Would you recommend extubation or tracheostomy or elective postoperative ventilation with endotracheal tube for hemimandibulectomy with the PMMC flap? Which one you prefer?
Sir, can you just repeat it again? You want to ask the elective ventilation?
Elective ventilation. What you will recommend? Extubation on the table or tracheostomy or elective postoperative ventilation with endotracheal tube for hemimandibulectomy with the PMMC flap?
Absolutely. I think this is an important question. So when we do an hemimandibulectomy with PMMC flap, it depends upon the extension of surgical procedure. So many of the times when the PMMC flap and the hemimandibulectomy done, our usual process is in 99% of patients, we keep them electively ventilated for 24 hours with good sedation, and we extubate them the next morning. Tracheostomy, we usually do not do for these patients. I think hardly, I don't remember. Even in the last 10 years, I have done any tracheostomy for these patients who have undergone hemimandibulectomy with PMMC flap as such. So on-table extubation depends upon if it's a small tumor, but as you said, hemimandibulectomy with PMMC, usually these patients are not extubated on table. But if there is a small excision of the mandible, the excisional and then reconstruction, in those patients can extubate. But for hemimandibulectomy and PMMC flap, it will be a good idea to ventilate for some time, usually 24 hours, and we extubate them next morning.
So another question, whether we can keep the flexometallic tube in the postoperative ventilation, or we have to change to a vortex?
No, absolutely. I think there is no issues. We usually insert them a nasal flexometallic tube for all our patients. So there are no issues. Yes, I agree. If you see the previous some evidences, they say the internal diameter of the flexometallic tube is not too big, and that's why there will be issue to change them. But we do not change any.
Sir, go. We
usually keep them.
Bhaskar, please mute yourself.
So we usually keep them on flexometallic tube. We don't change them because change of tube is a big issue in these patients, because just after surgery, we cannot maneuver the airway too much. There will be a lot of edema. So we keep them on a flexometallic tube and extubate them next day, depending upon the situation, sometimes directly, sometimes on an airway exchange catheter.
Sir, that's all the questions in the chat box.
Dr. Rakesh. Dr. Rakesh?
Yes, sir.
Yeah, I have two questions because your neck swelling slide is interesting. So the two questions are pertaining to that only. You said ultrasound is emerging as a tool for airway assessment. I want to know whether in such a big swelling, with such a big goiter, neck swelling, whether ultrasound linear probe will have the depth of penetration. That is one. Number two, for these large tumors, we used to intubate with the flexometallic tube, and once the job is done, surgery is done, whether you will extubate them on the table, or in your experience, how many tracheal collapse you have seen, how you have managed?
Right. I think both questions are very important. So when I said the ultrasound is not specifically for the large thyroid mass that I have shown it. I just mentioned it for overall of head and neck cancer. So we use ultrasound for all overall head and neck cancer just to have an assessment. And sometimes, for example, say we are getting a head and neck cancer, we need to identify the cricothyroid membrane. So these tools are not help in those situations. So they have an emerging role. Obviously, with a large thyroid mass, specifically when they are calcified, the use of linear probe will not be of any help as such. So probably this will be a limited aspect here. But then yes, in the post-operative period, after the thyroid surgery, even the ultrasound help us to look for whether there was any nerve injury. So we can see the vocal cord movements in these patients. So this is how the ultrasound is having an emerging role in these type of head and neck cancer, where you can pick up on not only for assessment for airway management, but also the complications in the post-operative period. So this is one aspect. Second thing is you said about the extubation after the surgery. So usually we assess these patients intraoperatively. When these large thyroid mass are for a longer duration, so these patients may have the cartilaginous softness, so they will have a tracheomalacia. So usually we ask our surgical colleagues that how the cartilage are looking us. So they can usually compare and tell they're looking softer, they are collapsible. So based on this, we take a decision. One, history, a long-standing goiter probably will have thyroid, will have tracheomalacia, softening of thyroid cartilage. This is one. Second is intraoperatively, the surgical assessment of the cartilages if they're looking soft. So this is the second assessment. In case of any doubt, we can do a leak test, as I mentioned in my slides also. If the leak test is not there, if there is no leak after the deflation of the cuff, this itself shows tracheomalacia. Now, in this situation, two options are available with us. Usually we extubate them next around 24 hours later. We don't extubate them on table. Usually in 24 to 48 hours, a lot of fibrosis will happen around the cartilage, around the trachea and the peripheral tissues. And that fibrosis, that inflammatory fibrosis will prevent the tracheal collapse to happen. And we can reassess the patient for leak and then extubate on either on fiber optic guidance, we can see for the collapsibility and reinsert the tube if required, or maybe on the airway exchange catheter. This is the most common options that we do. In some of the things, usually sometimes we do something called a surgical suturing of the trachea to the strap muscles. So this will keep the airway patent, and that can be done in selected group of patients when there is extensive amount of the tracheal cartilage damage because of the large thyroid mass. So this is the other option that we do. The tracheostomy is a rare phenomena. We have not doing tracheostomy in these patients. majority of patients, we are able to manage it. I think one tracheostomy out of 100 patients that would have been required, but 99% of times we are able to manage them conservatively, effectively, without the need for tracheostomy.
So the last question, what is your experience about submetal intubation, sir?
So submental intubation, we are not doing for the surgical procedures. Recently, I'm not doing it, but usually for various mandible fractures. For the maxillofacial surgeries, we have done it a couple of years back, and we were doing it routinely. But for the oncology setting, the submandibular submental intubation is not required for majority of these patients because the nasal airway is patent for majority of time, and the mandible or the teeth are not being, the wiring is not required for these patients, because these patients either will go hemimandibulectomy or mandible excision or maybe a central arch removing with plating. So the submental intubation is usually not the phenomena here. This is one. Second, we need to, in the oncology setting, we should be cautious about the planes. So we don't want to create an extra stroma because that becomes a potential site for metastasis. And hence, we should be avoiding these type of interventions in oncology setting. And there is no data available for submental intubation in these type of surgical procedures, because the reconstruction becomes an issue. The neck dissection becomes an issue. The placement of PMC flaps is a big issue. So submental intubation is not a good option for head and neck surgical procedure. It is one of the good options for mandible fractures and their repairs.
Thank you. Thank you so much for your excellent discussion. Kumar, I have hand over the session to Sudarshan.
Okay.
Can you hear me, Kumar?
Yeah, yes, sir.
Yeah, well, one of course, just opinion from Rakesh. Rakesh, hope you can hear me. Rakesh, there's nothing special about it. Just like an add-on, because I have not done tracheostomy for any of the head and neck surgery for the last 2 decades. Let me start from there. Question here is, we keep, because even whatever large thyroid tumor, what is showed and all those things, we have been nebulizing the patients with local anesthetic 4%, and we are able to put a tube with the fibrotic one. Do you need nerve blocks? Question, anatomy distorted, everything. And I think if you're in good communication with the surgical team and all those things, everybody knows their role. What's your experience nebulation with local anesthetic 4%? And then it just get into the area of, that was the thing what was being done those times about the nasal intubation. And I think
absolutely,
of course, still a slightly smaller tube, and that solves the problem. But as a retrograde, what intubation, what you said about the retromolar, whatever the thing, medicine is gone up because it's just got technology available in many places. If some place is not available, we have to insist that we need these things so that we don't do tracheostomy, because tracheostomy itself adds morbidity. Like in hospital stay for a patient goes on for another 1 or 2 months. What's your feeling, Rakesh?
Absolutely, I fully agree with you, sir. Creating a surgical airway or creating a separate path for submental intubation, having a tracheostomy increases more of a morbidity in these patients, and especially in the oncology setting, we need to avoid it. So absolutely, I fully agree with you, sir. And with our experience, I think in last 10 years or so, when I'm specifically working in an onco center, we are able to avoid tracheostomy for majority of our patients. So we hardly do it, and we are successful. This is one point. Second, you talk about the nerve blocks. In oncology settings, again, you absolutely pointed out very correctly. Putting up a nerve block, superior laryngeal nerve block or transtracheal block is not a good option, because sometimes you are going through the tumor and you can put a tumor seedlings. And hence, putting up the blocks is not a good option for this. And that's why spray as you go is the best technique, which is very well accepted. You mentioned about nebulization. Nebulization is a good option, but sometimes it leads to more of an drug delivery to the lower airway rather than the upper airway. But yes, it has been a part of the topicalization technique. It can be used, and spray as you go is the accepted norm, sir. So I fully agree with you, sir.
Let me share with you. I'll tell you, because this particular nebulization, I am doing for almost 3 decades. The narrowest part is the anterior nares. Narrowest part, what you see, for example, if the question is, if the tube is the question, normally you take like oral intubation, you might 7.5 for maximum for women and 8.5 for men. It can go plus or minus 0.5 here and there, and not a big deal. The antenatal can, the only thing is you feel resistance about antenatal, and usually we nebulize and then we put some, we go half, one half. Like, for example, if men want 8.5, we go to 8. Or if 8 was this thing bigger, we go for 7.5. And we get the job done, and at the end of the day and all those things, you want to change it to oral tube. Who said no? The nasal tube is only for the sake of securing the airway and all. What surgery is when you change it, if the mouth opening has been done, I think it all depends on skill of the team. Rather than going the prefix, my SI, I'll do this way only, or I'll do that way only. No, it's not like that. You have to communicate with your team. And yes, one thing is for the tube going in and all, and of course not to create you too much of pressure, because you are under pressure. Don't put the pressure on the tube, that it creates a soft, the fast passage. So I think communication with your entire team, the nursing team and the surgical team and the post-operative team, it makes sense. Because I think you have to evaluate your own technique and all those things. Nerve blocks in oncology, onco-anesthesia with the distorted airway, it may not work and all those things. It's a traumatic experience for the patient and for the family. Definitely, tracheostomy is not an option. Rakesh, your thoughts?
Is there any questions, sir, further?
I think whatever sir has mentioned is absolutely very important points which Dr. Joshi has mentioned. I think they are worth considering. He mentioned an important point of airway management in head and neck cancer. And two terms that he used is very important. I would just like to repeat them. One is the team approach, and second is the good communication. So these are the two things which had a successful outcome of these patients. We should be very, very cautious of communicating clearly to our surgical colleagues, to the critical care person, to the nursing professionals. And we have seen that this good communication throughout the procedure leads to an uneventful outcome. And team approach is important, because even though I have a good experience in airway management, but I may not be successful every time all alone. I need a good support from everybody. So I keep along the technical staff who is very supportive. I teach them how to manage it. They understand what I require. My surgical colleagues are with me. The fellow colleagues are with me. If I am having a difficult airway management, I just keep colleague in my adjacent operating room to be ready, and in case if I'm managing it. So I think this team approach and good communication is the crux for uneventful airway management. Thank you, Dr. Joshi, for such a good inputs.
Thank you, Rakesh.
Can we conclude, sir? Edward, sir.
It's your call.
Thank you,
Kumar.
Joshi, sir. Can we conclude? Or?
Please, it's your call.
Yeah, okay, sir. Thank you, sir.
Sir,
I think our academic chairman, Dr. Sudarshan, is not well. He couldn't continue further here. So I'm coming on his place. So we had an excellent opening session, and the great opening batsmen, Dr. A.L. Meenashitra sir and Dr. Rakesh Kag sir. They did a fantastic job in terms of delivering a great lecture on supraclavicular airway devices as well as airway concerns in head and neck onco-surgery. And we had a very good moderators by our National Academic Chairman, Dr. Joshi sir. In spite of his disturbed network, he was very keen and completely involved in moderating the session. Thank you, Joshi sir, and thank you, Edward sir. They did a fantastic job. So with this, we can conclude the session of today's academic program. And from next meeting onwards, we'll have a academic program involved by each branch of ISA Tamil Nadu. So they will be involved, and their contribution will be there, and their activity report also will be presented during that meeting. So with that message, I conclude this academic program and hand over the session to Dr. Bhaskar. Thank you.
Thank you, sir. Thank you, Mr. I thank the speakers, moderators, and the academic chairman for conducting an excellent session and a very good discussion from the participants also. Now I call upon Dr. Giridharan, our treasurer for ISA Tamil Nadu, to render vote of thanks. Before that, I want to make an announcement that this meeting, CME meeting, will be conducted every third Sunday of every month, involving the city branches of Tamil Nadu. And the next meeting will be on 2022, and we are getting medical counsel. Sir?
On request, Bhaskar.
Yes, sir.
Whatever chat are going for the speakers, so please pass it on to them so that they can communicate to the concerned participants. So that will complete the exercise. Bhaskar, please think about it.
Okay, sir. And thanks, sir. Thanks for the advice, sir. And now we are also making the announcement that we are getting medical council credit hours from next month onwards, sir. I hand over to our treasurer, Dr. Giridharan, to render the vote of thanks.
Thank you, Dr. Bhaskar. I take this opportunity, good afternoon to all. I take this opportunity to greet you in this New Year occasion and also welcome you all for this first academic program organized in this New Year by our new organizing team. And I thank on behalf of all our Tamil Nadu ISA office bearers to all the national office bearers who graced this occasion. Personally, I thank the national president, Dr. Venkatagiri sir, and past president and the chairperson of this session, Dr. Muralidhar Joshi, the president-elect Bhimeshwar Rao, our secretary, Dr. Naveen Malhotra, our treasurer, Dr. Virendra Sharma sir, and also our co-chairperson, Dr. Edward Johnson sir. And also I thank the two eminent speakers, Dr. A.L. Meenakshi Sundaram sir and Dr. Rakesh Gar, for giving a good lecture and having a good interactive session with the audience. And they also started a new organizing session for this academic year. And also I thank the senior dignitaries of the national as well as the state ISA who came and participated and graced this occasion of the new CME program. I also thank the colleagues and friends for attending the CME and gracing this occasion. I thank the Neon companies for supporting the CME and sponsoring the CME, and they have given us the assurance that they will support in the near future. And also I thank Dr. A1 Logistics for organizing the virtual meet in a grand way, in a good coordination. I thank you one and all for all the participants and gracing this occasion. Long live ISA. Thank you.
Thank you, everybody. So, President sir, can...
Yeah, we can close the meeting. Yeah.
Yes, sir. Now we can close the meeting, sir.
Thank you. Thank you, everyone, and take care.
Thank you, sir.
Thank you
Thank you.
Thank you, sir.
Thank you, sir. Thank you, madam. Thank you, sir. Thank you, everybody.
Praveen, thank you. You can close the meeting.
Praveen, you can close.
Okay.